Give or take 48 seconds. Yeah.
Okay. Well, this is really for all of us. And if you want to ask questions as we go along, that's fine. I've got the clock up on the wall over there, so we'll go as far as we can get. But I'm really excited to share the story that I'll call today MotoMeds. And that is not a company, it's not an NGO, it's the name or the brand for the initiative that we've been working on within academia to build better systems to improve access to healthcare for children and their families. And when I say families today, I'm actually going to say mothers, because most of these households are matriarchal, and it's really all about the moms and their kids. And this is within the domain of the University of Florida. We have technology partners called Trek Medics that builds EMS software for global health settings. And then my project director's name is Molly Klarman. She won a second place award for innovation in healthcare from the American Society of Tropical Medicine and Hygiene for this initiative I'm showing you today. And then Alpha is a group of undergraduate marketing students who cobbled together a lot of the images that you'll see today. Should I start? Okay. So at MotoMeds, we believe in making healthcare available to all children. We do this by combining eloquent clinical guidelines, durable technology, and a process called human-centered design to make solutions that are desired, feasible, and viable. We just happen to work in some of the most challenging settings in the world, and the solution I'll be going through with you today is called MotoMeds. So our challenge is, how do we provide children like this one here early access to high-quality pre-emergency care before they dip in to an emergency situation? This is incredibly important because many settings in this world do not have 911 services, ambulances, or there's tremendous barriers to accessing EMS services if there are some, which I'm about to go into. For those of you that work with challenging issues in your careers and in your lives, there's a process called human-centered design, which was additionally developed by a group called IDEO in a for-profit design company in San Francisco. The Gates Foundation about 10 or 15 years ago asked them, could they convert their design process from a for-profit mode of designing a toaster or designing a better fire alarm pole, could they bring that thought process over to the global health setting to help people like me build solutions for very complicated problems? And so this process is in three phases. There's a hearing phase, a creating phase, and a delivery phase. And then on the y-axis, it goes from a really concrete thought process. Let me see if I can draw that. There, a concrete thought process to a more abstract thought process. So if you go from the left side, human-centered design begins with making observations, gathering stories from communities, looking to see how those stories coalesce around themes, and then often through that process, opportunities and solutions emerge from the communities you work with, and those solutions sometimes can mature into viable prototypes, and then you can prototype those in an implementation phase. So it goes from concrete to abstract and back to concrete. And in this mindset of human-centered design, ideal solutions are those that are desired by what the tech industry will call the end user. They're feasible just from a logistical standpoint, and then viable from a financial standpoint. So we went through this process when I first moved to Gainesville. We established a public health research lab in Haiti, and we spent a couple years doing this process called human-centered design in Haiti. And we actually did a parallel initiative in Bangladesh, which I'm not going to show, but it was interesting because both Bangladesh and Haiti had very similar challenges around this, which is that families face barriers accessing what their intended provider. There's a difference between what families wish to do, intend to do, and what they actually can do. So if you interview a household, they'll say, well, look, I want to go to my intended conventional provider, but there are barriers of poverty, geographic isolation, now nighttime presentation of illness, violence, stigma that block them from seeking care from their intended. So what often happens is that they pivot to a less intended provider, which might be a non-conventional provider, or if an emergency gathers steam, they might have to then go all the way down to the hospital, which can be financially quite devastating for families. So what we began asking was, could we come up with a creative bypass across this barrier so we could link households to their intended provider? And as I thought about this, we really felt that the solution must address barriers during acute crisis. And my prior work was all around cholera outbreaks. And these are 3 individuals in hypovolemic shock from cholera. And basically at home, oh, look who showed up. Welcome. We worked together this past week. So as I thought about this initiative, everything I'm teaching today was really inspired by Danielle and I working in Port-au-Prince in 2010 in the cholera outbreak, in which we had a pretty good onboarding of clinical skills and epidemiologic capacity at clinics. But every morning, we had a queue of patients showing up in shock because they didn't have access to basic knowledge, advice, and oral rehydration solution, which is like Pedialyte, overnight. And so I began asking, how can we extend care to those households at nighttime? And so each of these 3 individuals had failure to access the care early. And so I felt like the solutions that we were working on needed to help individuals like this, but they also needed to work in situations with chronic crisis. And so most of what I'm talking about today actually was inspired by a conversation with this mother here on the left who said, look, I'm an Islamic woman. I live in rural Bangladesh. My husband pulls a rickshaw in the city. If my kid gets diarrhea or cholera or respiratory illness at nighttime, I can't just leave my household at night to go to the pharmacy and get some amoxicillin or Pedialyte. There's stigma, it's dangerous, and I have other children at home. So I said, okay, well, what do you do? And she said, well, I call into the pharmacist. And the pharmacist, out of professional duty, will answer the call at night, and we will figure out a way to get some basic medications across that divide at nighttime. So through a lot of design work, I basically took what she told me to do and wrote it down on a placard about 9 years ago, and I began thinking about how can we actually formalize this. So we began crafting together this concept of a telemedicine and medication delivery service, putting together a marriage between information and medication in hand. And so that really begins the story of what has, over the last decade, become this initiative called MotoMeds. So I'm a planner, and I really feel like with a good plan, you can achieve great things. And part of that begins with a hypothesis. And I'm a scientist, so I always begin with a hypothesis, which is that when resources are limited, morbidity and mortality can be effectively reduced at lower cost by facilitating early access to pre-emergency care compared to late access to emergency care alone, especially at night. And many of you are parents, and you've probably had a sick child here in Gainesville at 1 in the morning and asked, okay, what do I do? Do I wait till the morning and miss work, or do I go to the emergency room? There's no in-betweener, even in Gainesville. So this is a shared challenge everywhere. And so beginning soon after I came to Gainesville, we put together 4 clinical studies called the Improving Nighttime Access to Care and Treatment Studies. And this was funded by the National Institutes of Health all the way through in Act 2. And then Act 3, it's been donor-based. And in Act 4, hopefully will be NIH-based again, but is currently donor-based. And so the needs assessment was in step 1. Step 2 was looking at, can we launch a pre-pilot of this initiative really focused around safety and around logistics? Can it be done? And Act 3 is focused around scaling, and in Act 4 is a true deployment of this initiative at scale to see how it starts to get stressed as you go bigger and bigger. From an ethical perspective, this work has a lot of oversight. We get ethical approval from the University of Florida. We work with the government of Haiti and have approvals from both institutions. We're very aware of conflicts of interest, and so we do not have any conflicts of interest to my knowledge. From a medicine perspective, we have a clinical oversight committee that's staffed by physicians both in Haiti and in the US. And then there's many security issues. I'm not going to go into great detail on those today, but I just let you know that this is an initiative that carries a fair amount of safety concerns with it. So the mental model that I work with is that we're familiar with EMS services is one in which you have an ambulance that goes from the household to a centralized location. And from a clinical perspective, it's relatively easy. You have to make sure that the patient basically maintains a pulse and is breathing throughout this journey from the household back to the centralized resources where you can escalate care, and all the resources are there. What we're doing is we're saying, can we take resources from a centralized location, take them out to the household, make a good clinical assessment that they're not going to escalate to an emergency status, and give them Pedialyte or amoxicillin, and that they're going to be fine overnight. That is clinically really hard to do. And so we began challenging, can we take the classical EMS pathway, flip it upside down, and start moving resources along the green arrow? We're not the first people to do this. This is a model that's more prominent in Europe. France and Germany have models like this where actually we'll put a physician on an ambulance and basically do an advanced kind of home visit, and the patient won't come in to the hospital. So again, our measures, we're really looking at feasibility and desirability and safety in this first study. Our workflow is as follows. Good morning. Is as follows. We have households with kids 10 years and younger that call into us. And if they have a life-threatening situation, they do bypass us. And if they don't have transport, we'll send a motorcycle to them to get them to a hospital. If they pass that first triage as having mild or moderate illness, then we go through a formal triage assessment and plan. And then if they live within our delivery zone, in this first study, what we did is we sent a nurse to every single household. And the reason why we did that is because we had to verify if what we heard on the phone was actually seen at the bedside. We're the first team ever to start building a pediatric clinical guideline for this sort of service in a global health setting. There's not a WHO guideline for this. So we had to begin building that guideline using the household visits as our reference standard. If they lived outside of our delivery zone, they did get advice. And all households, we call back 10 days later to see how they're doing.
Eric,
Yes.
what was your percentage return on that? For, like, if you're sending nurses out to every call, like, how many of them actually needed a nurse?
I'll get to that. So what does this look like? So these are the sorts of roads. These are locations without electricity. There's no street lights. There's no address system. The roads are often, this is actually a good road, but often they turn into donkey paths. And then because we work in places that are unmapped, our drivers carry Garmins, and as they go out on every delivery, they're slowly mapping the roads that they access. So this white circle is the circumference of our 5 kilometer exclusion zone. So we try to keep them within this domain, and then you can see just, I don't know if you can see from where you're sitting, but it's a mountainous terrain. It's a very difficult terrain. but leveraging the local brilliance of the drivers, their incredible knowledge of this space, they can make deliveries in ways that no one else could. So this is a clinical flow diagram for how we conduct our research studies. We'll have a population that we screen, those that meet our inclusion criteria. In this case, in this first study, we had nearly 400 patients enrolled. Most of them lived within 5 kilometers. Some of them did not. And then we were able to follow up 90% of them at 10 days to see how they did. So going...
Call centers are there in that.
Yeah, so the call center is in this community. It's staffed by Haitian nurses. It has Haitian physician oversight. And then we've established a pipeline with the nursing school just south of our call center as a training pipeline to have career development for the nurses in the community. So our call length is about 20 minutes. Our time to delivery is 80 minutes. And we made up a phrase called the silver 2 hours, which is if we can get medication to a household in 2 hours, we think that's about the time that the clinical exam will hold that we do at the call center. And I was shocked that we get there in 80 minutes. I have ordered Indian food in this community and not had it arrive in 80 minutes. Not at the fault of the restaurant. And then in terms of intended deliveries completed, 98%, 10-day follow-up, 92. So why do people call? We had conducted a needs assessment, and luckily our needs assessment matched what we actually saw, which is that fever, respiratory illnesses are a primary driver. What was not expected was the degree of skin disease that families have. So diseases of extreme poverty are scabies in this context. And scabies we usually think of more of the nuisance, but in this context, these are nodular scabies that cause bacterial secondary infections, and the kids are actually very sick. And so this was not something that was on my radar when I started this, but has become a very dominant feature of what we do. So, yeah.
I'm sorry, how many of your patients on that 400 actually have telephones? How did they communicate to the, were all of them?
So most of these communities are saturated with just standard kind of feature phones. And the trick is not do they have a phone, but do they have power and do they have enough minutes? But every community knows on what mountaintop they need to stand to have line of sight with a cell tower. So it's usually, most of our calls are dropped, and then we call them back because we end up paying for the call. So this is the match of what we hear on the phone and what we see at the bedside. About 83% of the calls are mild as we deem them at the call center, and about 91% are mild when we go to the household. 6% at the call center are identified as red. They bypass us, and those go to the hospital. Now, 2% were not deemed as red, but when we go to the household, they actually are. So that's 1 out of 50. And then the yellows are as shown. So in terms of how they're doing on day 10, this is what allows me to sleep a little bit more, which is that if you add the blue and the orange, 63 plus 32, that's 95%, are improved or recovered by day 10. So this is heartwarming. And I have to think about, there is a small wedge that's less than 1%, and there is that 1 out of 50 kids that when we go to the household is actually sicker than we thought they were. Okay, so that is, yes?
Control group for that?
It's a good question. Control group. So what would happen if we didn't have this service would be the control group. That gets into ethics. So it's really tricky to have a controlled study because you'd be in a situation of denying a community something that most likely is going to be working, which is this question of equipoise. And this line of work doesn't lend itself well to equipoise. But it's a good question. There are ways to getting at your question, but in this study, we're not having a controlled trial. That's a great question. So what I just showed you was feasible and relatively safe, but is absolutely not scalable because I can't send a nurse to every single household. So then we asked the question, this next study is, we wanted to see the test of safety can be maintained when mild cases receive medication and consult alone, but do not have a nurse visit. If we go back to that pie chart I just showed you, what would happen if we took nurses off of this 83% of the deliveries? I did not know. But that was the pathway to scaling. So we launched a study early in the fall of this past year. And guess what happened? There was an earthquake right after we launched. And this was south of our call center. And this is in the Southern Peninsula, and this picture comes from Okai, which is the third largest city in Haiti. And we are experienced enough to know that in the first kind of 4 weeks to 8 weeks, there's this acute period of trauma and rescue and stabilization of communities that have crisis like this. But then afterwards, usually those first responders go home. And diseases like pneumonia, HIV that was being controlled by medication is now blooming because access to medication is not available. So there's a second phase of mortality that happens kind of months 2, 3, 4. And it's often because of the more chronic illnesses or things like, I don't know, cough and diarrhea come on board and start causing morbidity and mortality. So we were positioned for the first time to be present and able to step into that need. And when you have little money and you have a crisis, you have to ask yourself, is this the right thing to do? Because you're taking a risk of destroying everything you've built, in this case up in Gressier, north of this area. But through, I think, some right-minded thinking, we had a starter grant from Cisco, and we were able to go forward. And our challenge was, could we get a new MotoMeds up and running in an area with a natural disaster within 3 weeks? So we had planned on doing a hub and spoke model where you have a hub, in this case being the orange dot, the call center, with a spoke going out to Gressier, which is our delivery zone, and then building spokes over time to more and more places in Haiti. And in this case, we just did it to Okai. So once we began thinking about scaling, we're already launched our study where we take the nurses off of 83% of the deliveries. We just built this site in and then just went with it that we would also do the same thing where 83% of the deliveries in Okai would not have a nurse going to them. And it was a big shakeup and required a lot of oversight, but the workflow ended up working well, where you have a family in Okai, calls into our hub. The hub does a triage assessment and plan. We now have on-call nurses in these communities with mobile pharmacy backpacks. If the call requires a nurse visit, a yellow case, the nurse is called, she joins the driver and goes to the household. So this study is ongoing, and we've pushed so far beyond this 427 for enrollment. We're over 1,000 now, because as soon as we launched, there was a tremendous need, and our enrollment started going up faster than we expected, which is sort of what you want. And one of the reasons why we expanded the study was that we needed to verify the next day if the families understood what we had instructed. So we're now doing an adherence study on top of this study. But we're finding that, in fact, households with nurse visits are 12%, households without nurse visits are 77%, which is spot on what we anticipated. So challenges that we faced in this new expansion was connectivity. Working in refugee camps is its own complex engagement. looking at appropriate and inappropriate guideline deviations with new and old providers, then also security challenges. Unanticipated benefits. I'm realizing that some of the most important accomplishments we're making is actually not at the unit of children or child lives saved. It's actually at these other intangibles. The idea of hope is probably the most important thing that we have done in these communities, where you have marginalized households that have always been denied access. And now they can call a number and someone picks up the phone and answers their call. It gives them hope. Other things, capacity building. The economy and political system of Haiti has been destroyed. So having a pathway where someone can go into a nursing program, become a nurse practitioner, and onwards to us provides, I guess, another aspect of hope. School uniforms are incredibly expensive in Haiti. So often kids can't go to school because their parents can't afford the uniforms. But our moto drivers now are making a steady salary, and they can buy uniforms for their kids so they can go to school. So there's this really like wonderful trickle down that's happening through our employees, and we have it's growing, but we have about probably 30 people employed between Gressier and Okai. All right, so I'm looking at the clock, and I got about 5 more minutes. So paths to scaling. Taking the nurses off of 83% of the vehicles was one of the paths to scaling. But as we've scaled to Okai, there's more challenges. How do you scale safely? How do you reduce the rates of guideline deviation at the call center and in the field by the providers? The guidelines are in some ways simple, in some ways complicated. They require several months to train into the guidelines. And can technology play a role in facilitating some of that onboarding? The other aspect is efficiency for training. Okai is hard to get to. You may have heard that there's a rumor that Christian air transport airplanes are in cahoots with the government, and they've increased the rates of transporting aid equipment, and those increased rates are going to the pockets of the government. That's the rumor afoot. And so an airplane was attacked at the Okai airport, lit on fire, and rolled down the road. And so there's all kinds of barriers. So when you're in these sites, you have to work very efficiently. So right now what we're doing is we're writing the study for the ENACT 4. And what we're going to do is a pre-post study in which it's not really a controlled trial, but we'll have a pre and a post. In this situation, we're building software over the next 6 months that automates the clinical guidelines to reduce call time, increase adherence, decrease guideline deviation, run the study for 6 months. At 6 months, give the software, and then look at those performance metrics afterwards. And the reason why that's important is because we have to make sure that we get our mild diagnosis correct. If we mess that up, the danger starts to rise. So in this study, we're really interested in can technology increase guideline adherence? Can we decrease training time with technology? Can technology decrease call time and decrease time to delivery? Does cost per patient decrease with scale? And what are the unintended consequences of scaling? So in summary, it's been quite a journey. We've gone through ENACT 1, 2, 3, going back to these words of desirability, feasibility, and viability from that human-centered design process. And we're now pivoting to this 4th phase. There is not going to be an ENACT 5, because at this point, we're ready to graduate, and I think it's time that I start an NGO and start to move this out of academia into a venue that's better suited for scaling. If you or someone you know wants to donate $22, which is the cost of a delivery for Motomeds. I get passed you these cards, and then if the cards fail, UF does have a donation site up for this. So in summary, I want to go through our mission again. We believe in making healthcare available to all children. We do this by combining eloquent clinical guidelines, durable technology, human-centered design to make solutions that are desired, feasible, and viable. I've talked primarily about Haiti today. I have a student who's a Fulbright scholar who just arrived in Ghana, and they're working with the National Ambulance Service to do the needs assessment this coming summer. And then they have a USAID grant to start to do that feasibility and safety study starting this fall and onwards to next year as the beginnings of Motomeds making its first big hop to another continent.
Congratulations.
So who are the heroes here? There are many, but I want to give a shout out to Molly Klarman, who's an American, who's lived in Haiti for 10 years. She's married to a Haitian gentleman. They have their kids. They live down there, and Molly's quite a character. She has not had electricity for 10 years, and she sees no need to have it. She could get a solar panel and a battery, but she just prefers to go to the market and cook her food the day of and just keep her life simple. And this is Lurby. He's, during his time with us, has gone from general practitioner to one of probably a handful of radiologists in Haiti practicing. He still takes calls for Motomeds every night. This is Yuseline. She's our head nurse, and she drives the show when Molly's in the U.S., which she is now. So thank you, guys. It's 11:05. Any questions?
Yes.
Go for it. Thank you, Andy.
Just wondering how the people charge their cell phones or their electricity.
Well, that's a good question. So there are lots of solar panels, and people will charge off of solar. Or if there's a motorcycle, they'll figure out a way to charge off the motorcycle battery. There's a lot of creative ways to get the cell phone charged. And then the cell towers are off of diesel, and so they all have a diesel generator. And so when there's violence, you'll start to see the cell towers go down because they'll run out of fuel. Yeah.
Forgive my ignorance, but does your program exist alongside government-sponsored medical care, or is there not?
Ideally, it should work in partnership with the government. We're ideally set up as a bridge between day, night, day, so that we could route families to like government services or non-government services the next day. The government healthcare service in Haiti is very broken down, and so that is hard to do. In Ghana, it will be part of the process. But both in Ghana and in Haiti, we do have government partners that advise us and get our weekly briefings. So there is a partnership. They don't have much capacity in Haiti.
And is it the government that requires the uniforms on children to go to school?
I don't know. It's definitely a cultural thing. And the kids, yeah, I think it brings a sense of kind of pride and professionalism to the schools. I don't know.
And at the expense of excluding kids?
To support school uniforms? Well, I mean, I guess I kind of gave an example of how if you provide a pathway to employment, then the parents will have money to put into the uniforms. That's often one of the most pressing financial challenges for families, right on par with food.
It sounds like it could be an easier pathway.
It does. Any other questions? Great, thank you, guys.